Thank you for that amazing introduction. Hope I can meet your expectations. So let's start with a joke. All right. Why do the appendages of cows are not called feet? Anybody? Come on. Because they lack toes, right? All right. Is this the... Anyway, so I'm here to talk to you about SIBO. And SIBO is small bacterial intestinal overgrowth. And hopefully I can work this thing. Have no disclosures. Objectives. By the end of this presentation, you should know what SIBO is, the ways to diagnose SIBO, discuss some of the treatments and some future diagnostics and treatments. Let's see. Most recent ACG guidelines define SIBO as the presence of excessive numbers of bacteria in the small bowel causing gastrointestinal symptoms. We've all listened to Dr. Shea yesterday talk about all the fructans that make us have all these lovely symptoms of abdominal pain, bloating, gas, distension, flatulence, and diarrhea. Lovely topic at the dinner table. So these bacteria, usually coliforms, typically found in the colon and include gram-negative aerobic and anaerobic species that ferment carbohydrate-producing gas. So some of the gut flora include the Cytobacter, E. coli, Pseudomonas, Klebsiella, Lactobacilli. For the proteobacteria, gram-negative bacteria, you see them here. The alpha protobacteria, in their, some Greek guy came up with this. So that's why you have all these Greek A through Z names. But the alpha protobacteria is the nitrogen fixing bacteria, the beta protobacteria, ammonia oxidizing arsenic resistant soil bacteria. The gamma protobacteria is where the Pseudomonas and Acidithiobacillus live. The delta protobacteria, ferric iron reducing and sulfur reducing bacteria. The epsilon protobacteria inhibit the digestive tract of animals. And the zeta protobacteria has a sole member, which is the Myroprofundus ferrooxidans. So why does it matter? Because these bacteria grow in our guts and give us all these bad symptoms that we don't care about. So mechanisms for maintaining small bowel ecological homeostasis. Of course, our guts, like the rest of our bodies, want to maintain homeostasis and not feel all these terrible symptoms. So we do these things like our bodies, our wonderful, wonderful bodies, produce gastric acid so that most ingested bacteria in the food cannot survive the acidic in the stomach. And so we decrease the bacteria that way. Pancreatic enzymes. As we just went to dinner and talked about EPI. Digestive enzymes in the proximal small bowel also digest bacterial products, and their efficient digestion of nutrients leaves less substrates for bacteria. Bile acids are the detergents of our body, and they can have an effect on bacterial membranes. The small bowel motility, of course, is a major issue for SIBO. Migrating motor complexes and other events cleanse the small intestines of debris. And of course, when that doesn't work, we encounter more issues. The ileocecal valve, it's another big component of SIBO. Any issues with the ileocecal valve is going to allow bacteria from the colon to migrate into the small intestine. And so we're going to have issues with SIBO. The immune system, also mucosal immunity may be important in the maintenance of a stable microbiota of the intestinal lumen. So SIBO has been linked to irritable bowel syndrome, inflammatory bowel disease, systemic sclerosis, motility disorders, like I mentioned, cirrhosis, fatty liver disease, post-gastrectomy syndrome, fibromyalgia, and chronic pancreatitis. All these symptoms have an issue with motility of the gut or problems with the ileocecal valve. And so the lack of motility is going to create going to be more prone to create more bacteria, accumulate more bacteria in the gut. 90% of cases are caused by the small intestinal dysmotility. Chronic pancreatitis, major risk factor due to the changes in digestive enzymes that break down the bacteria. All right, I'm going to come back to that one. So causes and associated diseases, of course, anatomy. If, like I mentioned before, any issues with the lack of the ileocecal valve is going to allow the bacteria from the colon to migrate into the gut and causes those lovely discomfort symptoms, changes to bowel composition, like in cirrhosis, changes to enzyme secretion, like in chronic pancreatitis, and immunodeficiency, IgA, can also be an issue. So any critically low IgA deficiency, anything less than 7 milligrams per deciliter with normal IgM and IgG, levels have like a 10 to 20-fold increased risk for celiac disease. So, so we see a reduction in IgA in patients that have SIBO. So can I, just a way to go back. Yeah. So 30% of patients with IBS do have SIBO, and we see them often. Dysmotility, like chronic intestinal pseudoobstruction, where there's barely any motility of the gut, is going to produce more bacteria to accumulate in the gut, causing more bloating, distension, discomfort. Narcotic use, of course, slows down the gut. So get the same issue. Radiation enteritis, where we have affected the gut because of the radiation. It also affects our propensity to get SIBO. Scleroderma, of course, in systemic diseases that also affect motility will also make us more propense to get SIBO. Neuropathies like diabetes, diabetic gastroparesis, idiopathic gastroparesis are also part of the motility issues that makes us more propense to SIBO. Small intestinal diverticulosis, just pockets to get bacteria to grow and flourish, also makes us more propense to SIBO, and hypochlorhydria, just because we change the acidity of the gut. So allows the bacteria to grow. So really, I should say diagnostics, current diagnoses include how this, and this is a very funny thing. How do we diagnose SIBO? The gold standard is these duodenal jejunal aspirates, and a positive SIBO test is defined as greater than 103 colony forming units per ml of aspirate. How many here do this test for SIBO? Exactly, exactly my point. Hardly anybody does them because, number one, there's a lot, it is invasive. So it's costly, and it's increased risk for the patient. And most of the time there is contamination in getting the aspirate. So hardly anybody follows the gold standard. Most everybody does the hydrogen and methane breath test. However, it is non-invasive. and it's less expensive. There's fewer risks than with the gold standard, but the accuracy of the test is affected by the preparation for the procedure. So we heard Dr. Shea yesterday talk about home test for home breathing test for detecting SIBO. If we follow all the procedures that need to happen for the breath test, we might find that a lot of false positives are going to happen, because we all know that our patients are all very compliant with what we tell them to do for the procedure. So here's what we instruct our patients to do for the breath test. So no recent use of antibiotics or probiotics for 2 to 4 weeks. No probiotic agents, no stool bulking agents 1 week before the procedure. Of course, we tell them that they don't have to stop their PPI, but there is diet limitations a day prior to procedure, including non-absorbable carbohydrates like starches and sugars. They have to be NPO for 12 hours before the procedure, in no sleeping or vigorous exercise 1 hour before the procedure, right? So they have to follow all these instructions. It would be very interesting to know how home testing will do with this. And then, of course, like I mentioned before, this motility definitely affects the results. So a test is considered positive if there's a greater than 20 parts per million increase in hydrogen, or a greater than 10 parts per million of methane concentration increase from baseline within 90 to 120 minutes. And of course, this has less reliability and validity than duodenal and jejunal aspirates, but as we all know, we barely do those. So mostly relying on the breath test. So a positive hydrogen test is mostly associated with irritable bowel syndrome with diarrhea and IBS mixed. A positive methane breath test is usually associated with IBS constipation. The current guidelines have reclassified the positive methane breath test. Now is also called the intestinal methanogen overgrowth instead of small intestinal bacterial overgrowth. And methane has been proven to slow down gut motility, causing more constipation in humans and animals alike. So in a study by Loretano and colleagues, patients with IMO responded well to treatment with rifaximin and neomycin. But the recurrence of SIBO after a course of antibiotics was 13% at 3 months, 28% at 6 months, and 44% at 9 months. This slide only shows you the first one is a positive hydrogen breath test. The second graph, or the B graph, is a positive methane test, and the third graph is a normal graph. So treatments, of course, target the microbiome and include systemic and non-systemic antibiotics. The only FDA non-systemic approved antibiotic is SIBO. For SIBO is the rifaximin. We still have issues getting it approved from the insurance. So there's the other systemic choices that we can also do. Treatments, diet, reduction of fermentable products like the low FODMAP diet that we talked about yesterday, with slow reintroduction of foods. One of my colleagues at Stanford, Dr. Spencer, who works with the microbiome, said that it's really important that while the patients are on rifaximin and following a low FODMAP diet, that we start the reintroduction then, so that by the time they are off antibiotics, they don't get a recurrence of their symptoms. No significant evidence to support pre or probiotics, but patients like them, and some feel that they are helpful, so we don't stop them from using them. Gut-directed stress management techniques. And we had lovely discussions about that yesterday. In alternative medicine, like in herbal medicines, Atrantil is one of those herbal medicines that has been used to reduce methane production by scavenging hydrogen ions and potentially acting as a cidal agent for methanogenic bacteria. And patients with IBS have reported less bloating and constipation when taking this remedy. So what is the future? What's happening? And why we talk about SIBO is what's coming down the pipe. Concentration of oxygen, it's this gas sampling with a telemetric capsule. We heard yesterday about we do capsule endoscopies and vibrating capsule that we talked about at DDW for constipation. So this telemetric capsule captures concentrations of oxygen, allows the capsule to be accurately localized in the stomach, small intestine, or colon, while the concentrations of hydrogen and methane reflect microbial fermentation, and it's expected to be available this year. The data can be sent via handheld receiver and mobile app to the cloud, where it can be analyzed to gain insight into gastrointestinal disorders, including the SIBO, IBS, IBD, and carbohydrate malabsorption and intolerance. The other future diagnostics are, of course, microbiomics and metabolomics to do targeted treatment. Questions? Yes.
So I'm new in the world of GI, so I apologize if this is a naive question, but it seems like a lot of the therapies for SIBO are completely opposite from all of